This lecture is about the common lesions of a knee joint. So this one is the meniscus lesions. So in history, first one is the onset. So the menisci move with a tibia in a flexion, extension, and with the femur in rotation. So if during flexion, external tibial rotation is forced instead of an internal rotation, abnormal stresses are applied to the meniscus and the tear is possible. Same is with the force tibial internal rotation with the knee in extension. So medial meniscus being less mobile is more prone to the injury. Athletes involved in a contact sports are particularly more prone to meniscus injuries in conjunction with the ligamentous tears. Menisci tears occur with the hyperflexion of a knee, especially during the weight bearing. In this position, what happens is that the femoral condyles have rolled back to articulate with the posterior aspect of a tibia articular surfaces. So, if further flexion is forced, once the medial menisci has reached the limit of a backward movement, the menisci are susceptible to being ground between the femoral and a tibial joint surfaces. This is true if a rotation is forced into flexion because a rotatory movement entails further backward movement of one condyle. So certain positions such as mining in which one must move about in a squatting position may predispose to the development of our meniscal tears. In athletics, wrestlers especially prone to this type of injury. Next is the site of pain. So person usually feels something give in the joint, often accompanying a deep and a sickening type of pain. Next is the nature of pain. So onset is usually sudden with an immediate deep pain associated with the giving way of the joint. So if hemarthrosis occur, pain is severe and a pain is generalized arising with the minutes of a injury. If longitudinal tear of a medial meniscus extends further internally and they pass the midpoint of the meniscus, the lateral portion may slip over the dome of a medial femoral condyle. Resultant locking of a joint lead to loss of 20 to 30 degree of a extension. Persons suffering a meniscus tear hesitate to resume activity immediately after the injury. Synovial effusion causing generalized pressure sensation may arise within hours after the injury. So effusion always accompanies a medial meniscus tear, but not always a lateral tear. Next is the physical examination. So in acute stage, first one is the observation. You observe the patient and the patient may hobble in on crutches with a knee held is slightly flexed and touching down only the toe. An obvious effusion may be present. And the patient may have difficulty removing the shoes, socks, and a trouser. Next is the inspection. So effusion may be noted especially in the suprapatellar region and the patient stands with the knee held semi-flexed. And the Halfway test may not be performed because of an incomplete extension and the skin may appear slightly red and shiny. Next is the active movement. So weight bearing inflection extension is nearly impossible and a flexion extension in a supine reveals capsular pattern if effusion is present, loss of extension if a knee is locked, causing distorted capsular pattern if effusion is present, and a non-capsular pattern if there is no effusion present. Next is a McMurray test. So McMurray test should not be performed if effusion restricts the flexion. It only applies from full flexion to 90 degree. If flexion is possible, painful click may be elected on combined external rotation and the extension if a tear exists in the posterior portion of the medial meniscus or on combined internal rotation and extension if the posterior lateral meniscus lesion exists. Next is a passive joint play movement. So rotation opposite to the site of a lesion may be painful, especially during the Applis test with a compression applied, and distraction with rotation should relieve the pain. Otherwise, these movements should be typically normal unless a ligamentous injuries also exist. Next one is the chronic tear. So the patient describes intermittent giving way of a joint, often followed by some effusion, especially if medial meniscus is at fault. So younger active person is usually suffering from a longitudinal tear beginning posteriorly and gradually extending entirely. So older persons may have a degenerative horizontal tear with sliding occurring between upper and the lower portions. Objective signs. So quadriceps atrophy, especially involving the vastus medialis, full range of motion but perhaps some difficulty or apprehension when performing weight bearing, flexion, and the extension, and positive McMurray test if posterior segment of a meniscus is torn, pain on force extension if interior segment of a meniscus is torn. Next one is a coronary ligament sprain. So patient usually describe a twisting injury followed by some minor swelling and a pain over the interior medial knee regions. Acute symptom usually subsides within the few days. If meniscus maintain a good mobility during a healing, the patient should have no further problem. Often coin ligaments become adherent to interior medial margin of a medial tibial condyle as it heals, resulting in a reduced mobility of this part of the meniscus. So in such cases, person develop a more chronic problem characterized by intermittent pain when adherent tissue is stressed, usually with activities involving external tibial rotation of the tibia on the femur. Next one is the objective finding. So quadriceps atrophy, especially if the vastus medialis is involved, point tenderness over the interior medial joint line, and a pain on external rotation of the tibia on the femur, but no pain on the valgus stress.